Hello, in neonatal anesthesia, some challenges require immediate, precise, and expert-level understanding. Today we're talking about one of the most critical, the anesthetic management of a newborn for myelomeningocele repair.
Welcome to the Dr. MEK Anesthesiology series. Just a quick reminder, this explainer is for your education and should never replace professional medical advice. The information we're covering is based on the Myelomeningocele summary from Open Anesthesia, which was authored by Dr. Debnath Chatterjee of Children's Hospital, Colorado. Okay, so here's how we're going to break this down. We'll start with the definition, then get into the pathophysiology and diagnosis. After that, we'll cover the really critical associated anomalies, move to postnatal care, and finish with the specifics of anesthetic management. All right, let's begin with the fundamentals. What exactly is myelomeningocele? So MMC is actually the most common kind of neural tube defect. What you have is a cleft in the spine and a skin defect, which leaves the spinal cord and the meninges exposed. And these lesions, they're most often found in the lower lumbosacral region. Now, you might see the prevalence in the US is about 0.3 to 0.4 per 1,000 live births and think that's not very common, but it's really important to remember that this still represents a significant number of newborns who are going to need our highly specialized care. Next up, let's get into the pathophysiology. To really understand MMC, we have to talk about the two-hit hypothesis, and of course, how we identify it prenatally. This hypothesis is so key because it explains the whole picture. There's the first hit, which is the initial failure in development, but then there's a second hit, that continuous damage happening in utero to the exposed neural tissue. So how do we find this? Prenatal screening is typically done between 18 and 22 weeks. We're looking at maternal serum alpha-fetoprotein levels, or AFP. And when those AFP levels are high, say 2.0 or 2.5 multiples of the median, that's considered abnormal, and it's time to investigate further with high-resolution ultrasound. On that ultrasound, one of the classic things you might see is what's called the lemon sign. It's this distinct scalloping shape of the fetal frontal bones. And along with that, you have the banana sign. This is when the cerebellum gets pulled downward because of the tethered spinal cord, giving it this convex shape. When you see both the lemon and banana signs, it's very strong evidence for an MMC diagnosis. Okay, now we're getting to a part that is absolutely critical for us as anesthesists. We have to talk about the systemic comorbidities that come with MMC. The thing is, with MMC, these anomalies aren't the exception, they're the rule. And every single one of them has major anesthetic implications, from the Chiari-2 malformation to hydrocephalus and all the way down the list. You are listening to the Dr. MEK series. Let's focus on that Chiari-2 malformation for a second. It's present in nearly all of these patients. For us, the big takeaway is the very real potential for a difficult airway and a compromised central respiratory drive. That's our immediate concern. And then there's hydrocephalus. Something like 70 to 90% of these patients will develop it. That means we have to be constantly vigilant about the risk of increased intracranial pressure and manage it very, very carefully.
So, we have the diagnosis, we understand the associated problems. Now let's shift our focus to what happens right after birth. Those first 72 hours are absolutely crucial.
There are 4 actions that have to happen immediately. First, position the baby prone or lateral, no pressure on that lesion. Second, cover the lesion with sterile saline-soaked gauze. Third, get prophylactic antibiotics started. And fourth, and this is huge, institute latex precautions right from birth. The goal is to get to surgery within 72 hours. And finally, this brings us to the core of it all, our specific anesthetic considerations for the surgical repair of the myelomeningocele. Before we even get to the OR, a thorough preoperative workup is non-negotiable. We're talking a full blood count, a type and cross match, a basic metabolic profile, and ultrasounds of the head and kidneys to see what we're dealing with, especially in terms of hydrocephalus. Now for technique. General anesthesia with an endotracheal tube is by far the most common approach. It just gives you that secure airway control you need when the patient is prone. But it's worth knowing that spinal anesthesia has been described as a safe option in some case series for very select patients. You are listening to the Dr. MEK series. The induction and positioning sequence has to be meticulous. You've got to use supports like towels or a donut ring to keep all pressure off the lesion. Some even use a lateral position for induction. Then, once the airway is secure, the move to the prone position for surgery has to be done with extreme care. And let's be very clear about this. Blood loss can be significant. especially with larger lesions. You have to anticipate this. Having appropriate, secure IV access isn't just a good idea, it's absolutely essential for safe management.
So, to wrap it all up, safe anesthetic care for a neonate with MMC really comes down to three things: a deep understanding of those associated anomalies like Chiari-2 and hydrocephalus, a focus on protecting the lesion and preventing infection immediately after birth, and meticulous perioperative planning, which includes positioning, latex precautions, and being ready for major blood loss.
We really appreciate you joining us for this explainer. To keep advancing your clinical knowledge, please subscribe to our channel and make sure you hit that bell icon. That way, you'll stay updated with all the latest content from the Dr. MEK Anesthesiology series.
We'll leave you with a critical question to think about for your own practice. When you're faced with this situation, the risk of considerable blood loss in these very fragile neonates, what is your primary IV access strategy? Thank you for your attention.